So now we can look at myocardial function. So how do you see the global function, that is the left ventricular systolic function, the left ventricular diastolic. Diastolic is relaxing, systolic is contracting. So between these two, there is a stroke volume. So naturally, when it's systolic, when it contracts, it pushes the blood out so that there is some amount of volume is gone. So what is the systolic function doing? Is it contracting well or is it not contracting? So that's how we evaluate LV dysfunction or LV function. So normally it will be about 60%. It will contract very nicely. But there will be some people will get 20%, 30%. There is LV dysfunction. So this can be some amount of regional wall motion abnormalities. Okay. So whether we should be able to do anything like a IABP or take him to an angio, all these things can also be done before we can get. If these people are having these and we have assessed with an echo, we can do such things faster. Then other one is the right ventricle. The right ventricle can also have an infarct, particularly the inferior infarct. We know that many people complain, I'm having gastritis, the pain is there, but it is not very much. I'm not able to eat properly. So in a person who is diabetic, you should literally suspect, is there any inferior infarct going on or any ischemia is going on? So that should come to your mind so that you can take next place. So other thing is the valvular heart disease. Now we know, of course, now the valvular disease has come down quite a bit because the rheumatic heart disease was very, very high when we started our careers. Of course, now also you do have, but you don't see it that much as it is now. I mean, it is not that high. But you know, in the valvular disease, the valve is not functioning very well. Sometimes they can get a fever. Sometimes they can come saying that I have some amount of valve problem, but I'm having fever, I'm having cough. So if the fever is not subsiding with the minimum things, it goes on. Nobody looks at the echo. These are the people when you have a mitral valve disease, aortic valve disease, or any of the valves, if they are diseased, you must look up for the vegetations. This is one important thing which has to come to our mind. So, typically the vegetations usually lie on the atrial side of the mitral valve and tricuspid valve, whereas on the ventricle side in the aortic valve. So this is what you have to look at. When you are looking at, you should look at the atrial side in a mitral or a tricuspid, and on the ventricular side in an aortic valve. Next. So that is another one is the aortic dissection. Okay. With the modern advent of modern scanners, CT with contrast has become the gold standard for an acute aortic dissection. But however, sometimes the role of transesophageal echo is also expanding. Sometimes they can very quickly see there is a little aortic incompetence or a pericardial connection or sometimes coronary involvement. All these things can also be seen to an extent. In some centers, it is also a routine for patients with suspected acute aortic dissection to be transferred immediately to the operating room where TOE is performed. As soon as anesthesia, you put the TOE and then you see that this become an investigation of choice. But sometimes we can also use the transthoracic, provided it is a little difficult to diagnose for a beginner. But I'm sure a cardiologist with number of testing, or if you've worked in the cardiology department, which I'll come to my last slide, you can still diagnose it with this symptomatology. Patient is very, feeling very, very shocked and it wants to sort of, he may faint, severe pain retrosternally in the center, and then he feels fainted. Sometimes he may have a fit. So all these things, and so sharp and stabbing pain is a very typical of this aortic dissection. Next slide. So in trauma, so I'm just listing out what are all the things we can look at in in echo in the ICU. So thoracic injuries, sometimes if you've got a rapid, you have a rush protocol, a focus, protocol is there. So very quickly you will assess whether it is in the lung, whether it is in the heart, whether it is in the main, this thing, main arteries. So, or it is in the pericardium. So you can easily make out what is happening to the mediastinum. Are there B lines? So this aortic dissection can also be made out to a fairly good extent if we get trained in them. See, that is the main thing. Next slide. Next slide. So you can have other ventricular pathologies. Sometimes we see interatrial defects. Suddenly there is an embolus which goes between the atria to the up. So these are a persistent foramen ovale, particularly in the young small children. There can be septal defects which were not diagnosed earlier sometimes. Then some mobile atheromas which may be there in the aorta. Then hepatic pathology may be also, suppose when you put it in the lower now. So these are all things which you can look at when you are having the echo, which you use in the ICU. Of course, in the emergency they use. Now I'll come back to the normal. So you always have to know what is the normal. Left ventricle up and the left atrium lower down on your right, right. So the ventricles, the apex is higher and the base is lower, and you have the right, which is much smaller, and the interventricular septum, and the pericardium, which is much lower down. Okay, so these are, I don't know whether I can show this. Yeah, here, something like that. Okay, so these are the various things which you normally make out, and this is the mitral valve, which is between the left atrium and the left ventricle, and the tricuspid valve, which all of you know. I'm just saying this is how the normal echo looks. So when it is, a video, you can see it is nicely contracting and relaxing, nicely contracting and relaxing. Is it contracting in that way? Can you see the free wall of the ventricle? And both the ventricles, are they contracting simultaneously? Is there any problem? These are all can be there. Next, please. So these are the, once you know the normal echo, what is the end systolic volume? The amount of volume which is there in the systole is 120 at the time of, and so 120 ml is there, and the end diastolic volume is about 50. So that means 70 ml is ejected. That is the stroke volume in an adult male. Okay. So these are important things which we have to remember. So the stroke volume is only about 70, and about end diastolic volume, if it is 50 is left. So 50 will be how much? The 50 cc syringe, only that much. But suppose if it is more, that means the end diastolic volume has increased. Why? Is it obstruction, or is it, decrease in the pressure? Is it increase in the pressure? Water, all that thing. So end diastolic pressure is 5 to 12 millimeters of mercury. So that is what. So this end diastolic pressure is almost equivalent to your the pulmonary arterial wedge pressure. So 12 to around 18, like that. This will be less than that. So whenever these pressures are going up, that means it is not pumping, or is there some problem. Then other one is the end systolic pressure. It is about 76 to 160. That's the normal thing. So if you know these pressures and you know the volumes, then you can easily make out, is the volume more, is the volume less. So you can find out looking at the size of the ventricle and looking at its end diastolic volume. You can say whether there is enough volume or more volume. Does you require to give a fluid? Don't require to. Even that is possible. Once you know it, that's why you have to learn it. So the other one is velocity time integral, is an easily measured in the echocardiograph stroke volume index analog. So it always gives you that. So once you measure, it is seen there, then you can easily make out. This is usually between 20 plus or minus 3. So between 70 to 23 centimeters indicates normal stroke volume. It is more or less, then you will be able to know depending upon that. Yeah, next. So suppose the chamber sizes. Left ventricular end diastolic area is less than about 10 square centimeters. And the index, something like that is there. But just remember, the left ventricular, this one. So obliteration of the left ventricular cavity would be seen in severe hypovolemia, right? Suppose if this is your left ventricular, okay, And if it gets, okay, this is the one. This should be the normal left ventricular. This. Suppose if it becomes very small when you see it, so you can think there is hypovolemia or not. Is there anything else? Then you look at the muscle. So this all question again goes back to the clinical.